but someone, okay. So ultrasound guided celiac and superior hypergastric block, we have look at the respective locations. Usually, celiac is situated at the level of the L1, whereas the superior hypergastric is situated just in front of the lower border of the L5. Whole of the L5 is one disc and in front of the S1. Now coming to the indications, here there are mainly I have already told two types of indications for which we go for the celiac plexus block. One is the pain of the upper abdominal cancers. For example, it could be a stomach cancer, it could be a pancreatic cancer, pancreatic head of pancreas cancer. That is a very common indication for the celiac plexus block. In those cases, we can go for the celiac plexus block, or sometimes it could be a metastasis to the upper abdomen. In those cases also, suppose the patient is having liver mets, that is painful, it is also an indication for the celiac plexus block. Whereas in chronic cases like chronic pancreatitis, we usually perform celiac plexus block to reduce the pain. Remember, there's a misconception among a lot of pain physicians or physicians, I should say. What happens that when we are putting the celiac plexus in chronic pancreatitis, if the pancreatitis flare ups, then also the patient will not be able to understand the pain. Reality is not that because however meticulous your neurolysis is, actually some fibers are always remain spared. So what happens when you do the celiac plexus block in case of chronic pancreatitis? Pain intensity definitely reduces. But it doesn't happen that when there is flare up of pancreatitis, the patient will not be having pain. Definitely, the intensity of pain, what is before the celiac plexus block and what is after the celiac plexus block will be different. But the up and down of the patient will be understood by the patient and for which the management will not be hampered. Let's go. Structure. Now we all know there are three splenic nerves. In the abdominal area, when the nerve supply of the sympathetic is concerned, mainly three splenic nerves, the greater, lesser, and least splenic nerve, they are the main supply for the abdominal organs. Now the question comes that whether these fibers are preganglionic or postganglionic. Remember, these fibers, unlike in other areas, these fibers are not postganglionic fibers. Because if you see for the sympathetic, usually the ganglion is situated away from the organ. And what happens? This is a general rule in most of the cases like upper limb, lower limb, or upper or in case of head and neck. So everywhere, this general rule is that in the sympathetic, it is from the lateral horn to L2, the fibers are coming, and then they are first coming to the sympathetic chain, from where they are relaying, and from there the postganglionic fibers actually go to the organ. Here there is a slight difference. These fibers are preganglionic fibers and they run by the side of the vertebral body of the T11 and T12. So here is the T11 and T12. Then they continues and they pierces the crus of the diaphragm. And anterior to the crus of the diaphragm, in front of the L1 vertebral body, anterior to the aorta, close to the celiac trunk, they forms a ganglion from where the postganglionic fibers actually go to the respective organs. So here, instead of relaying in the sympathetic chain, they are continued as a form of the sympasplanchnic nerves. Usually, the root value for the greater splanchnic nerve is T5 to T9, whereas the lesser splanchnic nerve it is T9 to T11, whereas T11, 12 or sometimes T12 alone forms the loose splanchnic nerve. They continue at the side of T11 and T10 vertebral body, sorry, T12 vertebral body, and then the level of the L1 appears as the class of the diaphragm that we can see, and then just in front of out they form the celiac plexus. Remember, celiac plexus or celiac ganglion is not a small ganglion, it's a large ganglion. So you can actually do a neurolytic block here, but you cannot perform a radiofrequency ablation at the level of the celiac ganglion because of the large size. Because we know size of a radiofrequency lesion, conventional radiofrequency if it is actually 2 to 4 millimeters. Within that diameter, it is not possible to cover the celiac ganglion neither by repositioning again and again because the vessel is there. So we cannot do like that. So in celiac plexus, the main mode of neurolysis is a chemical neurolysis. Okay? It is not the radio frequency ablation. But if you want to do a radio frequency ablation, what you can do? You can, instead of going to the celiac ganglion, you can come to those splanchnic nerves because they are running by the side of the T11 and T12. You can block by the side of T11, T12, and that will be a splanchnic ganglion block and radio frequency ablation. That is possible with the help of radio frequency. In most of the chronic cases, like in case of chronic pancreatitis, nowadays a number of physicians prefer the splanchnic nerve radiofrequency ablation rather than the celiac plexus nerve. Because what happens if you do a neurolytic block, for example, if you are doing a full neurolysis, usually the pain relief period is around 6 months, maybe 6 months to 1 year maximum. Approximately more or less it is 6 months. Whereas in case of chronic cases, sometimes it is very difficult to repeat those again and again. For the palliative care for the cancer patient, sometimes it's okay because life expectancy is very less in those cases and go for a neurolytic block. When it comes to the chronic pancreatitis cases, it is usually preferred to go for a splanchnic nerve block rather than celiac plexus block. But splanchnic nerve block is mostly fluoroscopy guided and not today's discussion. So we'll be concentrating on the celiac ganglion. Now, from the celiac ganglion, the fiber continues as the superior mesenteric ganglion. Some fiber continues. Some fibers continue as the aorticorenal ganglion, and then these nerve fibers continue below and forms the superior hypogastric plexus. Then from their fibers continues below as the hypogastric nerves, they continue to the inferior hypogastric plexus, which is actually within the pelvic organs. In two areas, we can block those plexuses, mainly at superior hypogastric and the celiac region. In both the cases, it is the neurolysis that is actually being done rather than a radiofrequency ablation. So, in most of the areas, the radiofrequency is good. But here, it is the main block is the neurolytic. Now, we all know celiac trunk is a vertical branch. So, it is one of the vertical branches of the aorta. And anterior vertical branch, the first branch is the celiac trunk. Then we have the superior mesenteric artery. Celiac trunk, after coming out, divides into three branches. Here, two branches are shown because they are the main branches. There is a third branch also that is known as the left gastric artery. Other two branches are very, very important. One is the tortuous splenic artery, which is going along the pancreas and supply the spleen. And the other one is the common hepatic artery, which again divides into left and right hepatic arteries and then supply the livers. This is the location of the celiac plexus. So if we look at from the superficial to deep, for example, we're looking at an ultrasound from superficial to deep, what we'll see. So just try to imagine, let me draw also. So blood is coming like this, then that is coming anteriorly, then it is going left, and then it is going right. So under fluoroscopy, sorry, not fluoroscopy, under ultrasound, if we see aorta is moving like this. And just try to imagine and put them in a uh, sorry, round, not round, now it is combined. So what we'll be seeing? We'll be seeing a gush of blood that is moving up from the aorta. So that is the celiac trunk. And then we'll be seeing it is being divided into two branches. One is the common hepatic, one is the splenic. Now, this division looks like a flying seagull. That is why this is known as the seagull sign. So, where is the seagull sign here? This will look like a seagull. So, this is known as a seagull sign. And that is our sign for finding out the celiac plexus at from the aorta. So, let's continue with the next presentation. So, this, I think those who have already done the fluoroscopy guided part, they know this part of anatomy. So basically, these are the types of the celiac plexus block. So here, if we do from the posterior side behind the diaphragm, then it will be called the celiac plexus block. If it is done anterior to the crux of the diaphragm, that is known as the anticrural celiac plexus block. When we do at the level of the T11 or T12, I have already told you, it is basically the splenic nerve block. So basically, whether it's anticrural celiac plexus block retrocranial celiac plexus block or planking nerve block, we are targeting the same nerve. They are not different, but we are targeting at a different location. But in fluoroscopy, we can do all three types of block. But with ultrasound, we can do only one type of block, that is anticrural celiac plexus block, or we can call it ultrasound guided anticrural, or sometimes we can call it also ultrasound guided celiac plexus block sample. So you have understood that in fluoroscopy, if you take the needle, you puncture the aorta, come to the anterior side, it will be anticrural. To remain posterior to the classical approach around the L1 with both the sides, it will be the retrocrural. If you do at the level of the T11 to 12, it will be splagnics. All the three things is possible with the fluoroscopy, but with ultrasound, only we can perform as we go from the anterior side. So all we will bring the anticrural celiac plexus. And the scanning, how it looks. Remember, liver is a good window for us to see the celiac plexus rather than the stomach. Because in the stomach, there are sometimes the gas shadows, there are foods, and that actually impair the vision under ultrasound. Usually, we prefer the window of the liver. But problem is, if the coagulation profile is deranged, then there could be possibility of bleeding, and that sometimes happen in case of cancer patients. So in those cases, it is very important. If there is any abnormality, we need to correct it prior. Otherwise, it could cause difficulty. Or you can change our technique. Now, here, as we see, as this is a small branch, the left gastric artery, it is not usually seen in most of the cases under ultrasound. So while we start scanning from the xiphisternum like this, you can this picture, and then we start scanning down, and when we come to the celiac plexus area, suddenly we see a gush of blood moving up. Then it is dividing into anterior and posterior portions, and under ultrasound, it looks like this. Okay, so initially, this is the picture where we are actually seeing the vertebral body. So when we put the probe initially, we do not know which vertebral body is this. When we move and up and down along this vertebral artery, so we can easily see one side, this is the artery, and other side, it is the vein. Okay, it is the IVC, and one side we have the aorta. So we see aorta as a pulsating moving structure, and wavy pulsation is seen on the IVC as well. When we pace with the probe, usually only aorta remains. So IVC usually branches when you are actually putting pressure over it. Now, yes, we can see this is the IVC liver and this is the aorta. And in the longitudinal orientation, when we see, it will look like this. So what are those structures in the longitudinal view? Let's come one by one. So here the main artery you can see. This is basically the out. Now, first branch that's seen from the aorta coming up, this one is the celiac trunk. The next branch coming is the superior mesenteric arteries. They goes like this. Now, the branches of the celiac plexus you cannot see in a longitudinal view. Reason behind it is divided and it is going towards left and right. So here it's looking that it is ending here because it's a cross section. But when we look at this point from the transverse view, we'll be able to see this picture. So let us first go for this picture because it is better seen. So here you can see this is the aorta, and with pressure we have placed the IVC, it is here, and then this is the celiac trunk, and then we are having the divisions of this side it is the common hepatic artery, and this is the right side we have the splenic artery. So we need to find out this division. So if we give color, it will look like this, and this is the long axis view with the colored appearance. But remember, this type of clear picture is only visible if the bowel is properly prepared. Even in today's volunteer, I am sure I may not be able to see same because here the bowel is already seen, guys, shadows are there. Coming to the complications. What are the complications of the procedure? First of all, there could be bleeding, there could be retroperitoneal hematoma. There could be intravascular injection, accidental intrathecal or epidural injection, though it is rare with the ultrasound. But if you are not able to see the needle tip properly, or it has gone much inside, there could be possible. There are chances of perforation, pneumothorax, chylothorax. But remember, it is only with the needle. It is a very small perforation. And as we are already prepared the bowel and we are actually giving the antibiotic prophylaxis, so chances of infection were very less. Then obviously infection could be one possibility. Hypertension, diarrhea, that's a common effect of the celiac plexus block, because as we are blocking sympathetic, there will be parasympathetic overactivity, which can lead to the hypertension, similarly which can lead to the diarrhea. So sometimes it will be very difficult after the celiac plexus block, so you might have to give anti-diarrhea. Okay, like sometimes diphenhydroxylate or sometimes atropine, this type of medication sometimes may be rated. Now, among the other complications remains the importance paraplegia, thrombosis or embolism, though rare, it is possible that it might happen. So coming to the hypogastric plexus block. Now, hypoglastic plexus is indicated in the following structures if it is painful. For example, if it is bladder, urethra, uterus, vagina, vulva, prostate, penis, testis, rectum, descending colon, perineum. Any malignancy originating from these areas or infecting these areas can cause pain, which we can actually do this block. That means we can do the superior hypogastric plexus block. And in cases of endometriosis, radiation injury, old adhesions, chronic pelvic pain. So these are the conditions where actually we have to go for the ultrasound guided superior hypogastric block. Here also, bowel preparation is very important because here we have to go through the bowel nerves. So how to locate the L5 lumbar vertebral body?
Sir,
Usually,
sir, excuse me,
hello,
sir. Sorry to disturb, sir. Sir,
yes,
in ultrasound also we have to. What are the injectables we'll give, sir, here for
I'm
blocking
coming.
this?
I'm coming to the injected also.
Yeah,
So
okay,
let me
sir.
first demonstrate the procedure, then I will
Oh,
talk
okay, sir.
much further.
Okay, sir.
So what is there? So basically, here we have to find out aorta dividing. So aorta divides at the level of the L5. So when the aorta is dividing into left into and right common iliac vessels, that is usually the beginning of the L5 vertebral body or lower border of the L4 vertebral body. Now what happens at this area? Two phenomena takes place together. One, the venous margin, mainly the left common iliac vein, goes over above the fifth vertebral of lumbar vertebral body, and then it goes to the right common iliac vein and forms the inferior vena cava. At the same time, the iliac vessels are also dividing. That's what happens. Usually, this division of the iliac vessels is slightly superior. The arteries divide a little above rather than the union of veins. So when we see these areas, usually we see the left iliac vein crossing over to the opposite side. So obviously, we have to come slightly more down toward the fifth lumbar vertebral body where we are not seeing the vein. That is also very important. And after this, we have to put the needle either left or right side. Here there is no difference. In celiac, I am telling the liver is having certain advantage. So stomach is having certain a disadvantage. So here it is not like that. Whether you go from the left or right, ultimately you are puncturing the bowel. So you have to go and you have to hit the fifth lumbar vertebra and then you have to inject the drug. Now regarding drug, what is given? The most commonly used drug in the celiac plexus is the ethanol or 100% ethyl alcohol. Usually, at a concentration 50 to 90% is ideal for the neurolysis of the celiac plexus. And when you are taking any anterior technique, for example, if you are doing it through the ultrasound and going to the anterior portion of the aorta, here the volume required is 15 to 20 ml. That is the standard volume. So 15 to 20 ml of drug is usually given. That is a problem. Whenever you are injecting alcohol, especially the ethyl alcohol in this area, One thing you should remember that ethyl alcohol directly put over the nerve is very irritating and it causes a burning sensation. So initially, instead of injecting the ethyl alcohol, we usually inject 5 cc of local anesthetic so that the pain during injection of alcohol can be avoided. After that, we usually inject approximately 90% of ethanol, 15 ml. So total volume almost becomes 20 ml. Okay. And here, when we are doing under ultrasound, there is no point giving the dye. But when we are doing under fluoroscopy, initially a little dye is given, which colors the aorta. And especially if you look at the continuous view, you can see the movement of the aorta along with the dye. So it looks very beautiful. Anyway, it is ultrasound. We don't have that. So in ultrasound, initially we will be injecting 5 cc of local anesthetic and 15 cc of the 90% ethanol, and then again 1 ml of local anesthetic and take out. The reason behind we should not want to put an alcoholic tract to the out. This is very important when you are going from the posterior side because of the nerves are there. Also, there is a possibility there is a fistula formation remains, so for which we usually inject first saline and then we take it out. So that is why we have to do like this only. Okay. When come to the superior hypogastric plexus block from the anterior side, usually the volume is 10 to 15 ml. And here also we use either 90% alcohol or we can use 6.8% phenol. So both the things are possible to use, and phenol is having certain advantages because phenol is itself having a local anesthetic like activity. So it doesn't require prior injection of alcohol here. The problem of the phenol is in the different side, it is causes burns over the skin. So whenever you are injecting phenol, you should be very careful that you have put this normal saline gauge over the skin so that if accidentally it falls on the skin, it doesn't burn the skin. That is very, very important. But both the drugs, phenol and ethanol, can be used in both the areas. Regarding the phenol preparation, phenol is a very difficult to prepare because phenol is a very hygroscopic substance. So there is two way. Either you can make phenol in glycerol or you can make phenol in water. And the problem is if you are making phenol in water, going beyond 6% is very, very difficult because the saturation point of the phenol in water is approximately in between 5.8 to 6. At 30 degrees Celsius, it becomes almost 5.8. So in those cases, giving more concentration becomes difficult. So if you want to give more concentration, either you have to go for a comparatively hotter solution where the saturation point is higher, or you have to with the glycerol, sorry, phenol in glycerol. But in those cases, the ionization usually remains a little low. So the ideal is giving a saturated solution of phenol that's good enough. But remember, in most of the cases, when we use the neurolysis, we use the alcoholic neurolysis only. Coming to the complications. Among the complications, there sometimes could be bleeding, especially into the retroperitoneal space. Nerve injury, paralysis may be possible if you accidentally go to those areas. Puncturing the surrounding organs, it is possible. Puncturing the adjacent vessels and distal ischemia may be possible. So this is the anatomy that was I'm talking about. So at the level of just above the L1, the aorta start dividing, and then we have the division of union of the vessels also, and just below here and in front of the L5 and S1 we are having the superior hypogastric plexus block. So we have to go at the top and then we have to inject the drug at this point. Now let me show you the video first because I am not sure whether how it is possible to show in the volunteer, because every time there sometimes we got a very good view in the volunteer as well. Sometimes we do not got it. So I made this recording as well so that you will be able to understand how to perform it. So, okay. So we are scanning mainly in a transverse plane, and then we are seeing the in the left side in this picture. Just one second. In this picture, let me stop in a place where it is better seen. So this shadow, whenever we are scanning, usually we see this one. So in this big image, what we see both the things. Here it is the artery and here lies the vein. Okay, that is the first thing you need to identify. This is the liver tissue. This side it will be the hepatic tissue. So we have to identify first the vessels because vessels is the main landmark here. Once you have identified the vessels, you try to locate the vertebra behind. So where is the vertebra? Vertebral body? Vertebral body is here. Okay, let me show. If you increase the depth, you will be able to see better, but this is the vertebral body. Now we do not know which vertebra is this, whether it is L1 or L2, we do not know, but we know it is a vertebra. So at this point, we need to search for the, okay. So here actually in this image, when it was not the exact thing, you try to find out, okay. So now in this picture, the things are much clear. Actually for this patient, volunteer, there is celiac artery is not straight. Celiac artery was a little bit carved. So basically, so initial image what I have shown you that was not the celiac artery because it was above. I have actually I have taken this video long back, so I forgot actually. So these both the things here, both the things are arteries. Actually, the vessels are here. Okay. So this is one vessel. This is another vessel. This is the artery. This is the vein. Okay. And these are both the arteries because this case was a little atypical. Here we had a little bit carved celiac artery. So now you see, try to see the celiac artery. So this is basically the image. Just one second. Okay. So this was the celiac artery. This is the aorta. This is the celiac artery. And then it is dividing into its two branches. You will see it is a little bit carved. I have taken the longitudinal view for this volunteer as well. Okay. Sometimes it is not cutting the whole of the celiac artery clearly. That's why you can see this type of image, this type of cross sections. Okay. Let me go to the longitudinal view. Okay. So this is with the color. So this is the aorta, this is the celiac trunk, this is the common hepatic, and this is the splenic. Superior hypogastric I have also demonstrated here, but superior hypogastric will be able to see. That is not difficult. So let me go and demonstrate and let's see how much of it we can see today. Hello. Hello. Am I audible? Uh-huh.
Yes, sir.
Okay. So scanning starts from the leafy sternum. So দেখা যাচ্ছে না? একটু উপরে নেবো। ঠিক আছে, মুখে নেই, মুখে নেই, মুখ দেখা যাচ্ছে না, তোর মুখ দেখা যাচ্ছে না, চিন্তা করিস না। সো উই আর স্টার্টিং, এটা আমি দেখতে পাচ্ছি না, লাইট কমিয়ে দাও না। ওকে, বন্ধ তো, বন্ধ, ঠিক আছে, দাঁড়ায় দাঁড়ায়, বন্ধ করে দাও। আরে ঠিক আছে, ও হ্যাঁ, তুই তো মুশকিল, লাইট গুলো এত বেশি। হ্যাঁ ঠিক আছে, এখন বেশ ভিডিও দেখা যাচ্ছে তো, ভিডিও তো দেখা যাচ্ছে। Density গেলাম আর কি। So now what we can see the liver tissue. So at the level of the xiphi sternum, whatever we see in the screen, the whole of the liver tissues. Now as we are going further down, so at this point, again the gas shadows, that is the problem. In fact, in most of the time, in the evening time, we got a lot of gas shadows here. Let me try to find out if I can get any window. So this is basically the colon shadow covering everything. So whether we can got any window among this or not. Let me scan a little longitudinally whether we can manage to. So now we are actually doing a transverse scan, sorry, longitudinal scan to find out the aorta, because I want to make sure that whether I have any space for it or not. Okay. So here the large shadow which is at the center, it is basically the shadow we are getting, the shadow of the large bowel. So let us try going from below, because here we can see a little bit of the superior mesenteric artery as well. Okay. আগে আমি একবার ইয়ে করার চেষ্টা করি, যদি সিলেক্টকে নিচ থেকে টার্গেট করতে পারি। So at this point, if we come down, we can see two arteries here. The artery below is aorta, and the artery above is the superior mesenteric artery. And you see these two arteries? Let me show you the pointer. So here is one artery, here is another artery. The artery below is the aorta, the artery above is the superior mesenteric. So somehow under this shadow, we are having the celiac trunk. But let's try by going from a plane below, whether we can get anything or not. So at least we are able to appreciate two vessels here. One vessel we can see at this point, though there are a lot of gas shadows, images are not very clear, but we can see, I am showing with the pointer. See at this point. Here, the structure with the respiration, it is moving, the gas shadow is coming in between, but sometimes there is a gas shadow, sometimes you can see an artery, where my cursor is. So this is the aorta, and this is the inferior vena cava. Okay. So right side is the aorta, left side is the inferior vena cava, and below we have the bone. So let us increase the depth, it will be clear further. Below we have the bone. This is the bone. This is the vertebra. Now we have to follow the aorta. From the aorta, now we can see some gush of blood moving towards the left side of the screen. So it is not always visible, but sometimes we can see. Okay. So try to see with the respiration, it's moving, but you can see one blood column is moving at this point. Okay. Can anyone appreciate? With respiration, it will be changing. It will not remain fixed. Okay, so at this point, you have to observe one blood column moving up. So that is the celiac trunk. And remember, every time getting a pure sigil is sometimes difficult. So what we have to do in those cases, we have to just go for the close to the sigil and near the aorta and drop the drug just above the aorta. So here we can see the celiac artery and here is the division. Remember, it is coming sometimes but not always there because there is a big gap shadow and this gap shadow sometimes is obscuring the picture. But in some occasions we can see this is the common hepatic artery that is going towards the liver, towards the right side. And this portion is the portion of the common hepatic artery. And the other portion, if possible, just one second, it will come in between. So here lies the splenic artery where my cursor is. It is going through that area, but again, it is coming sometimes with the respiration and sometimes going with that. Okay, I can ask one thing. জোরে শ্বাস নিয়ে একটু ধরে থাকতো। Okay. No, there also portion. Now it is visible. See, in between the gas shadow, we can see small portion of it. ছেড়ে দে। Okay, ask the patient to catch hold the breath, and then a little bit of it is visible. But there is a big gas shadow in front. Okay, let us try whether it is possible to give a little color to it or not. আবার শ্বাস নিয়ে ধর। No, it is not taking possible because lot of gas shadow. We are not seeing it continuously. Sometimes we are seeing, and some most of the time it is a gas shadow. Anyway, so this is the location for the celiac plexus. But remember, celiac plexus, we need a good bowel preparation. Otherwise, it is not possible to see. Now going for the superior hypogastric.
Do we need to go in plane or out of plane approach for this?
So here mostly it is done under in-plane approach. Okay.
Oh.
So when I am telling it is from left side or right side, that means I have to go either from the liver in plane or either from the stomach in plane.
But the structures we see are on cross section, sir. Actually, I mean transverse section. I mean,
Structures we see on cross section. There is another technique also. We'll find where it is given in longitudinal approach from below upwards, but that is not the conventional technique. The conventional one is seeing the structure, celiac trunk, and then going close to the aorta or just above this sigil. So when you can see clearly the sigil, then you have to put it just above the sigil. And with the respiration, you have to synchronize your things. That means it is not that every time you will be able to see the structures. Okay. So that happens during procedure as well. Here also there is too much gas shadow. That's why it is being obscured many times. But still with the respiration, you have to go. But injection should be given in short axis only.
Okay, sir.
Okay, the classic. The other one, longitudinal view is also there. That is also in-plane technique. That is also not an outer plane technique. Now we are seeing the aorta a little below, just above the
Hello, sir.
umbilicus. Hello.
Sir, I just wanted to ask you about the length of the needle. I mean, which type of needle we would use? Either spinal needle 23, 25 gauge or Chiba needles. I mean, here there's a possibility we have to go more depth from the anterior side. So
See,
your opinion, please.
whether you want to take out Quinky or Chiva is not a problem. Usually it is commonly done with the Quinky needle. So we have usually most of the cases with the normal Quinky needle, if the patient is very lean and thin, with normal size Quinky needle is possible. Or sometimes you can go for the 12 centimeter or 15 centimeter Quinky needle. They are also available. Okay. Chiva, though we have some Chiva needles, but we commonly do not use the Chiva needles here. Most commonly we use the Quinky one.
Right, sir. Thank you.
Okay. So now we are seeing the aorta and we are seeing the vertebral body. Okay. Now I am going down to find out where this aorta actually divides into two. So at this point, we see aorta is divided Here, fortunately, we don't have much gas shadow, so we can see all the structures very clearly. Okay. So here what we can see? We can see basically three structures. One, you can see this one. This is the vertebral body. Then this is the left-sided common iliac artery. Here we are having the right-sided common iliac artery, and in between the arteries, we can see another vein here. This is the left common iliac vein crossing over to the right side. So when we are getting this structure, we have to go a little more down, where actually we will be able to see the vertebral body, and in both the sides we will be having the iliac vessel. And this sign also sometimes looks like a frog. So that is why sometimes it is known as the frog sign as well. And just at the top or head of the frog is our target. So from either left or right side, again in plain view, just go above the head of the frog, and then these are the eyes of the frog, these are the eyes of the frog, this is the head of the frog. So just go at the top of the L5 vertebral body, and then you inject the neurolytic here at this point. Clear? This is comparatively simpler and easier actually. Huh? So here, as I told, there is a vein that is crossing. As I go down, the vein will be ended. Then over the bone, we will be injecting. Okay, not into it. Okay, sometimes it might happen at this point. If you are putting pressure, the vein may blanch, and you think that I am giving inside in the celiac plexus, but in the superior hypogastric plexus, but actually you are injecting within the vein. So you do not do that. Just come a little down where the vein is ended, and here you can actually inject it. Okay. Now here it is joining. Now at this point it is joined. It is dividing. Okay. So it is very simple. It is not difficult. For the celiac, sometimes yes, it is difficult. So sometimes in some patients we have to go or change the view, or sometimes from the ultrasound we have to change to the fluoroscopic if the anatomy is not clear. So usually assess the patient before, that way that you will be able to achieve clearly with the ultrasound or not, then only go for it. Otherwise, you can shift to the classic approach as well. Okay, so the next part will be
Okay, so if you have any question, you can ask about these two procedures. Otherwise, I will talk about the thoracic part. Thoracic actually, thoracic and abdominal wall. So, in thoracic and abdominal wall, there are only few things which are related to the chronic pain. Otherwise, most of the pain syndromes, they are related to the pain problems. They are mainly related to the post-operative pain. The procedures which are done in this area, they are related to the post-operative pain mostly. Otherwise, only few things are related to the chronic pain syndromes. So here you can see.
Sir,
Yes.
sir, in advanced carcinoma, if there is involvement of the great vessels by the cancer mass,
Yeah, then we will not go for the celiac plexus neurolysis anyway, because then we will not touch that area. If the aorta is involved, then we will go for only splanchnic nerve neurolysis. Okay. What are the things which can cause, I mean, when patient can come to you with a chest wall pain or abdominal wall pain? So some nerves can be affected, like post-herpetic neuralgia, it affects the intercostal nerve, or thoracic radicular pain. Sometimes it is possible, say in a case of vertebral fracture. So after that also someone can have thoracic radicular pain. So these are the common nerves involved. Otherwise, musculoskeletal, some conditions are there which can cause chronic pain, like costochondritis or Titt's disease. So these are nearly same, though not completely same. Okay, so costochondritis is one condition, and then comes arthritis. So there are few joints like menobriosternal joint, sternoclavicular joint, or even xiphoidalgia, pain of the xiphoid process, that is also possible. Then comes fracture of rib, sternum, or cartilage unhealed. It is going on and on for a long time. That also can cause pain, and patient can come to you as a non-healing pain. So then comes other causes like say post-thoracotomy chest wall pain. So this is also very much common, post-thoracotomy pain. So post-thoracotomy pain is not a specific disease. So it encompasses all the other causes. Post-thoracotomy, maybe there is a neuroma formation, so the pain is coming from the nerve, or say there is a some other structure due to the muscular pathology also. I mean, the pain can come from the muscle also. So onset of pain or pain generator can be from different structures. So it is an umbrella term. Then comes scapulothoracic bursitis. So this is a type of bursitis which is just under the scapula, and or it can cause the snapping scapula syndrome, like when patient is moving his hand, then there is a snapping sensation under the medial border of the scapula. So that is another entity. Then comes sleeping rib syndromes, referred pain can be there in the chest. Fibromyalgia also can cause total thoracic cage pain. Then Mondor's disease, bony metastasis, or sickle cell crisis. So these can be possible for a patient to come to a pain clinic for when the patient has chest wall pain. Okay. So post-herpetic neuralgia, you know that this type of presentation can be there, and you can go for the nerve blocks or epidural steroid injection, or some other procedures also are there. But then nothing is 100% effective. That's why we cannot say that any one method is the treatment of that. But this is common for chest wall pain. Thoracic radicular pain, as I told you, it's many times it can come from the, like a lumbar radicular pain. Thoracic radicular pain is also possible when there is a maybe vertebral fracture. So in those cases, thoracic epidural steroid injection can have some effect. Intercostal nerve block, radiofrequency ablation. So these also have been tried. Now costochondritis. Here a local anesthetic steroid block is a very good treatment of costochondritis. Bony metastasis, of course, there are different type of techniques are there, not a steroid injection. So metastasis, if there is a bony pain, then of course there are multiple different techniques are there. I'm not going into that because ultrasound guided, it is not ultrasound guided. Okay. Then comes, so let us talk about some amount of anatomy, sonoanatomy and pathology. So here, this you know that in our thorax, so where is the plane, which is the plane where the intercostal nerve flows or intercostal nerve passes. So we have, okay, so this is the intercostal nerves plane. Okay, external intercostal, internal intercostal, and innermost intercostal. So between these two, innermost and internal intercostal, it is the area where the intercostal nerves are found. And with ultrasound also, we can find in the lower margin of the upper intercostal of the upper ribs, that we can see by the ultrasound. Okay, then comes, these are the, as I told you, these are the joints which are involved. So by ultrasound we need to see that if the costal cartilage area is looking normal, we have to compare with the opposite side also, that both the cartilage looks normal or not, and whether the pain at the costochondral junction or not. Okay. Nerves, so we know that how the nerves are supplying the chest wall. So there are some cutaneous nerve, anterior cutaneous nerve and lateral cutaneous nerve. So before, if we are going for the intercostal nerve block, so and or the other procedure which targets the intercostal nerve, then we must target before it gives the cutaneous nerves, lateral cutaneous nerve branches. Okay, before it gives, then only the block will cover the total area. So I'm not going in here. So you just remember the brachial plexus formation here, root trunk division cord. So all these divisions are there. So in roots, just you see there are two nerves, dorsal scapular nerve and one is long thoracic nerve. These two nerves can be seen in the thoracic area. And the long thoracic nerve is a completely motor nerve, and we do not need any such any treatment of pain syndrome. But dorsal scapular nerve, it can give rise to local myofascial pain of the upper back. So there are different techniques of hydrodissection in the myofascial planes. So that targets the dorsal scapular nerve, that I will show you. So there are one injection is there, intervention where 5 injections are given. So for the upper myofascial pain. So one nerve is spinal accessory nerve, another nerve is dorsal scapular nerve, and 3 layers of muscles that I will show you. So from the trunk area, it is nerve to subclavius is not important for us, but suprascapular nerve we have seen in the shoulder ultrasound area. So that also in different pain syndromes we target the suprascapular nerve. Then from division area, division part, we do not have any branches. Then from the cord part, lateral pectoral nerve, medial pectoral nerve, thoracodorsal nerve. So all these different nerves come out and we can locate them. In a very unusual or rare cases, sometimes we may have to locate these nerves when there is a motor symptom also. And these all nerves are actually accompanied by different small vessels, like say lateral thoracic nerve. Lateral thoracic nerve is found in the between the pectoralis major and latissimus dorsi. So in the anterior axillary line, okay, anterior axillary line. So this is the lateral thoracic artery, and it is accompanied by long thoracic nerve. Long thoracic nerve and lateral thoracic artery goes together. Then comes thoracodorsal. Thoracodorsal artery, it is between the serratus anterior and latissimus dorsi muscle. Okay, so there we find the thoracodorsal artery and thoracodorsal nerve. Likewise, dorsal scapular artery and nerve also can be found in the medial part of the scapula, and this is important for myofascial chronic intractable long-standing myofascial pain syndrome treatment. Then comes so pectoral branches we can see in the front side between the pectoralis major minor or below the pectoralis minor. So while doing ultrasound examination, patient can be lying supine. We can see in the sitting position also when we are seeing from the lateral side or from the posterior side. And most of the time it is the linear probe which is sufficient, and we don't need the curvilinear probe for the wall part. This is the wall of abdominal wall or chest wall. Both the things, it is not needed to use the curvilinear probe, but sometimes may be needed also. So here few things I will show you. So intercostal nerve block already we have actually shown during the thoracic spine ultrasonography. This is the here when we are seeing the ribs continuously. This actually we see from the posterior side, say 7 to 8 centimeter lateral from the thoracic spine, from the midline. There we are showing seeing the ribs in a cross-sectional view, or in a sagittal section orientation. I will put the probe and I will see the ribs in a short axis view. So here in the lower part of the rib, lower margin of the rib, here I expect to see the neurovascular bundle. So this is the intercostal vessels. If I use the we will see the artery if we use the color, and with a very good probe, very high frequency probe, you may be able to see the nerve also. So incorrect and correct procedure difference is like when you are in the correct plane, there you give local anesthetic, it will depress the pleura. This is correct procedure. But if it doesn't depress the pleura and fluid goes upward, then it is not in the correct plane. While doing the intercostal block, you must check. So these parasternal blocks are not important for pain. Now pectoral nerves, we can actually locate the pectoral nerves, but this is also not important for chronic pain syndrome. Yes, maybe for acute pain, treatment of acute pain. Here there are some PEC1, PEC2 block. So these are also not for chronic pain syndrome. Okay. Long thoracic nerve and thoracodorsal nerve, we can surely see that where is the location. Tit syndrome, costochondritis. So as I told you that we will locate that if we can find the, we have to locate the cartilage part and the bony part. And at the junction of the bone and cartilage, if the pain is there, then it is a costochondritis. And we will of course compare with the both side. The affected side will be more hypoechoic because it will be more swollen and there will be more fluid. So it will be more hypoechoic or anechoic, you can say, and normal one will become a bit hypoechoic compared to the opposite one, diseased one, and diseased one also will be swollen. So here you can see this part has become swollen. This part, this is the sternal side, and this is a cartilage part. So cartilage, this part is affected. That's why this part has become more black, means more anechoic, and it has become swollen. So this is the ultrasound diagnosis of chondritis, you can say. Then comes sternoclavicular. So these are small junctions. So this is the sternum and this is the sternochondral junction actually. So sternochondral junction between the, so there also someone can have a joint arthritis by, and if you give a color, if you give color, you can see more vascularity there, but these are not very common. Okay, so enthesitis you can see. So in the costochondral junction also enthesitis can occur. Sternoclavicular joint also can get affected, and like any other joint arthritis, we will always see that bony margins are all right or not, and if there is a fluid accumulation or osteophytes are there or not. Like say here you can see osteophytes. So these are osteophytes, and some fluid collection is there, so these are abnormal joints. Okay, sternoclavicular joints. Manubriosternal joints also like that. This is normal, this is yeah, this is abnormal, completely abnormal. Here also these are abnormal actually when there is too much of vascularity, so these and other bony irregularities are also there. This part, dorsal scapular nerve and spinal accessory nerve. So this one I will just show you in a different way. So scapulothoracic bursitis, here some you will see in pain clinic many times patient will come and say that I have muscular pain in the medial angle of the scapula. So most of the time it is a myofascial pain only, but sometimes some patient can be a case of scapulothoracic bursitis. So here what we can see is actually the scapulothoracic bursitis. This part is scapula. This is bony scapula, and above that there is fluid collection. So you can see the corresponding MRI image. You can see that this is the area for fluid collection. So so this is also possible. If you see that, of course you have to aspirate and inject. Okay, abdominal wall USG. So why we need in abdominal wall USG? So mostly it is the important for post herniorrhaphy groin pain. Not only herniorrhaphy, there can be different other surgeries also, but mainly it is associated with post-herniorrhaphic groin pain. So which nerves are actually involved? Ilioinguinal and iliohypogastric nerves. Genitofemoral neuralgia also can be there. Scar neuralgia also can cause the similar symptom. But genitofemoral nerve, of course, we showed in hip ultrasound. It is more in the groin part, not in the abdominal wall. So they all can cause after the abdominal surgery pain, chronic pain, and abdominal cutaneous nerve entrapment syndrome. So here this is a TEP block, or say rectus sheath block is given for hydrodilatation of that small entrapping nerves. Okay, cutaneous nerve. These are all anterior cutaneous nerve entrapment is the cause, and this is also a myofascial. It causes a myofascial pain, local pain. There is a test called Carnett sign. Carnett sign proves that it is pain is not coming from the viscera, it is coming from the superficial muscle layer, abdominal wall layer. Sleeping rib syndrome. So here a pain treatment or intervention is not much indicated, but for diagnostic purpose, we must know that this pain syndrome exists and patient can come with this. Chronic abdominal wall pain. So chronic abdominal wall pain and anterior cutaneous nerve syndrome, nerve entrapment syndrome is a bit different in that sense. It is a the abdominal cutaneous nerve entrapment syndrome, a specific disease, whereas chronic abdominal wall pain is a umbrella term containing many diseases. Okay, then comes post-herpetic neuralgia that can cause thoracic pain also, thoracic wall pain also, abdominal wall pain also. So post-herpetic post-herniorrhaphic groin pain. So multiple studies has been done, and it has been seen that okay, the ilioinguinal, iliohypogastric, genitofemoral and lateral femoral cutaneous nerves are mainly involved, but I will say ilioinguinal and iliohypogastric is more involved. This is the abdominal cutaneous nerve entrapment syndrome. So here also different intervention like rectus sheath pain, rectus sheath interventions we can do actually. So then comes abdominal. So in abdominal wall USG, I will show you that where to go for the different blocks. Okay, this one I will not show. In blood supply part, so see this common iliac vessel, which becomes the external iliac vessel, and this one actually becomes the femoral nerve, femoral artery continuation. This is a continuation, and it gives rise to multiple different circumflex arteries. Lateral circumflex artery, this one we see when we do the intervention in the hip joint. So here also there are some other circumflex artery. So inferior, there are some other circumflex arteries, superficial. I will, so that actually associated with the ilioinguinal nerve. Okay, so those circumflex arteries. And so we will see by these probes. Sometimes it is needed for this curvilinear, otherwise linear probe is sufficient. So here these intervention are done in different cases. This is one rectus sheath block. So this is one rectus sheath block. Then comes TAP block. So as I told you, these are mostly done in acute pain conditions and not during chronic pain syndromes. So TAP block. Then comes deep circumflex celiac artery. I forgot the name actually. So this is associated with ilioinguinal nerve. Okay, and in the same plane only, a bit medially, it will be the iliohypogastric nerve. So this is more of a plain block. When you are thinking that this patient have post-herniorrhaphy pain and maybe these vessels are causing the neuralgic pain, you will give a lot of drug in the same plane for separating the ilioinguinal and iliohypogastric nerve. Okay, So QL block is not needed, osteoitis pubis. And lastly, counting the level, I don't remember whether I told you during the thoracic block, intercostal nerve block, during intercostal nerve block, whether I showed you or not how to count the levels, but I will show you again, no problem. Okay, so first thing, I show you the structures which are important just to see, just to locate. I hope everyone can see the screen. Okay, I hope everyone can see the screen, isn't it? Yeah. Everyone can hear me, no?
Yes, sir.
Okay. Because I don't understand if. So first thing which is very important, that is the ilioinguinal and iliohypogastric nerve. Okay. So ilioinguinal and iliohypogastric nerve. So first thing, I know this is the anterior superior iliac spine. As soon as I put the probe like this, so here actually my probe is today showing a artifact. Don't think about that artifact. Left side a bit of so this one, okay. Anyway, this shadow is artifact, okay. Don't this is my probe artifact. This, don't think about that. You just see from here. So what I have kept, this is the anterior superior iliac spine. So this is anterior superior iliac spine. I will just show I will probe, just rotate the probe. I will just rotate the probe towards the umbilicus. Here what I can see, I can see the 3 layers. If I do like this, sometimes the 3 layers are not very much clearly seen. So I will do like this towards the umbilicus. Okay. So here what I can see very nicely 3 muscle layers. Okay. So so 3 muscle layers are there. If I put color, so okay. So this is the plane. This is the plane. Sometimes the color is being taken and sometimes not. Here, this is the vessel. This is the vessel. So this is the neurovascular bundles. They all accompany together. The nerve is here, ilioinguinal nerve, and iliohypogastric nerve will be lying a bit more medial.
Sir, can you pause it and draw, sir?
Okay. I will show. Just wait. So here, as I told you, I have started from the anterior superior iliac spine. Okay, I have started from anterior superior iliac spine, and my needle, my probe is directed towards the umbilicus. But someone can start from the umbilicus side also. Okay, so here what we see, we can see both recti muscle, this is the rectus, this is the recti muscle. This is, of course, some fat area is there. So I'm just showing you. So this is rectus. This is rectus. This is linea alba. This part. And here some fat is there. This is some fat. Okay. So don't think that. And below that, of course, it is the peritoneum, intraperitoneal cavity. Now I will go to one side. So now I will go to one side. So here we have checked. So this is the rectus, rectus, rectus. Now I am going from here. So here what we are seeing, this is the linea semilunaris. So this is called linea semilunaris, where the rectus is coming and joining with these. So in this area also there are two lines many times. So this is not important, as I told you, in chronic pain, but there are two lines. There are two lines. So between the rectus muscle sheet and the peritoneum covering, if your injection comes from this side and goes in between, then that is the rectus sheet block. Now we are going this side laterally. So we are going laterally. So in laterally there are three layers. We can see clearly there are three layers. So what are the three layers? What's the external oblique, internal oblique, and the inner transversus abdominis. Okay, transversus abdominis. So here I will go towards the from the in this area. It is much easier to understand which are the three layers. So in this area I will go towards the anterior superior iliac spine. So here I can give color and I can show you. So this picture, let's see. Okay. So vessels are there, but see these vessels, okay? These vessels are iliohypogastric nerve, associated with iliohypogastric nerve, and ilioinguinal nerve also in this area only. It is so sometimes okay. Anyway, so you have understood that this is the third layer. This is the layer 1 and this is the layer 2. Okay, between 2 and 3, this is for iliohypogastric, and this area is for ilioinguinal, these nerves. So we can see the neurovascular bundle here, but of course every time it may not be taking the color. It may not be taking the color, but this is the how we catch the vessels, nerves, I mean, between second and third. So it is much easy. So now you can see that it is taking color. Okay. So yeah, now it is taking color. So this is the plane. This is the plane. Actually, many multiple vessels are there. So it is always better if you start the your ultrasound from the umbilicus area. So and then you come to the anterior superior iliac spine, so that you understand that which is the second and which is the third layer. Okay, between second and third layer we will search for it. Okay. Now comes some other now comes the costochondritis, as I told you. So what I am seeing here, so this part is sternum. This part is sternum. Okay. So as I am seeing the sternum, so if I need to see that whether it is the cartilage, the junction between the sternum and cartilage. So I have to put the probe in such a way that I am putting the probe in a long axis of the joint. So this is the cartilage. So here you can understand this part is sternum and rest this part is cartilage. Okay, this part is cartilage. But so this area, is the one sternochondral junction, and here we have to search for the costochondral junction. We will search, but you see how I have hold it. So it is not straight. It is the way I have hold it like this. The orientation of the, it is as per the orientation of the ribs. So I have hold it like this. Now, wait, I will go a bit up.
Sir, please can you hold it with your other hand? Actually, your hand masks the view.
Oh, okay. No, but then this is other end is a bit difficult because I have to operate the ultrasound machine also. So like this is the sternum in the middle part, and then comes the chondral part. Now I am going laterally. And suddenly you will see as the pleura is being seen down when I am on the rib, on the cartilage, but suddenly you will see that this pleura is no more seen. Okay, so this part, so this part. So this part here, this area, suddenly you will see that pleura is no more seen. Here you can see the pleura, and this is the costal cartilage. So this area is nothing but the costochondral junction area. So if there is you put the color and see if there is too much of vascularity or not. If there is a costochondritis patient, then patient will have too much pain here. Okay, so this is the area. And then in short axis also you can see, so this is one vessel I am seeing here. Okay, so as soon as I go here, so this is rib, because pleura is not seen, and suddenly pleura has come. That means I am on the cartilage. So here where I stay, so this is the area for costochondral junction. Okay, this side is totally rib, and this side is completely a cartilage. So you can compare two, three cartilages one after another. So if one you see that it is more hypoechoic, like anechoic, completely dark, and it is swollen, you can compare with the opposite side also. Then you know that okay, this one is due to the costochondritis. Okay. Then other joints I am not showing here. It is just sternocostal and sternoclavicular joint or manubriosternal joint. These are all same actually. There is nothing very. I mean, there is nothing to see as such. Okay. Now I will show you some two other. Mainly I will show you the dorsal scapular nerve, which is very important. Just a minute. Okay. Oh, cool. Okay. So he is sitting here, our volunteer. So he is sitting here. I am showing you. So before that, it is better if I show you the, just a minute, share. Okay. So as I told you that so many you will see in OPD that many patients will come with myofascial pain of upper back, and some people will say that okay, my medial side of the scapula is paining. So just to show you, so in these cases, if we know that it is from myofascial pain only, but then simple trigger point injection may not work. So in those cases, 5-in-1 block is practiced. So what is that? So here first you see this one is trapezius. I remove the trapezius. So what are the other muscles? Okay. So second group of muscle. First layer was trapezius. Second layer of muscle. What is this? Levator scapulae. What is this? Rhomboids minor. What is this? Rhomboids major. So I remove the second layer of muscle. So remember, this is second layer of muscle. So what is third layer of muscle? Serratus posterior superior height. Between, after that, of course, there is the this paraspinal muscles. I'm not talking about that. So this is the first layer, second layer, third layer muscle of superficial muscles. Here between the first layer and second layer, we will search for the spinal accessory nerve. Between second layer and third layer, we will find the dorsal scapular nerve. And you can inject between three layers. Like you can in three muscles. One is trapezius, one is rhomboid minor, one is rhomboid major. Again, you see, this is first layer. I hide. This is levator scapulae. This is rhomboid minor, and this is rhomboid major. These are all second layer. Okay, these are second layer, and this is the serratus posterior superior. This is the third layer. So you can between second and third, you will find the dorsal scapular nerve. Between 1 and 2, you will find the spinal accessory nerve. You can inject in all these three second layer muscles and do a hydrodissection of both the nerves in 2 layers. So just a minute. Okay, so this is a procedure for intractable myofascial pain syndrome for a long time. So how to understand which structure is what? So I'm showing you here. So I'm starting from the supraspinatus fossa. Okay, suprascapular fossa. So this is the supraspinatus muscle, and above that, this is the trapezius. This one you have seen when you have seen the ultrasound of shoulder. So these are 2 layers of muscle. This is scapula. This is completely scapula. You can see where I have kept the ultrasound probe. This is scapular spine. So I have just put the this probe above that. So I know that there are 2 layers of muscle. One is trapezius, one is supraspinatus. Now I am going medially. When I am going medially, then first layer is there, and second layer, what is that? So second layer, it has to be the rhomboids. This starts from here. So this is the rhomboid minor, and below that rhomboids major will be there if I come down like this. Okay, and there is a third layer of muscle. What is that third layer of muscle? So this is your serratus posterior superior muscle, and this is of course pleura, because I am in the intercostal space. If I go more, then I will see that it is covered by the rib. So here 3 layer muscle means, if I decrease the depth, so here 3 layer muscle means this is 1 layer, this is 1 layer, this is 1 layer. Okay, so now I am going a bit up, and to show you that between second and third, so this one is third and this one is second. So just see, between second and third there are some vessels. Okay, so what are these vessels? This is the dorsal scapular artery, dorsal scapular artery or nerve. So these are the vessels. Oh,
Sir, could you please draw, sir?
Drawing.
I mean, okay, layers.
Okay. So here, actually drawing takes time. That's why I'm just showing the pointer, but still. So this is the upper one is first. this one is layer 1, this one is layer 2, and this one is layer 3. Okay, so between 2 and 3 is actually this second one, third one, serratus posterior superior. It is very thin in this area. So between second, you just see that when you are seeing the second layer, either it is rhomboid minor or it is levator scapulae, doesn't matter. But just below this second layer, you will find one neurovascular groove. So this is the dorsal, this artery is dorsal scapular artery, and dorsal scapular nerve is just around that. So sometimes we can see the nerve, sometimes we cannot see. Yeah, it depends on your probe capacity. And above this, with the first and second layer, so in this plane, we will search for the spinal accessory nerve. So here also spinal accessory nerve also, has another vessel around. And when you give injection, your needle will come from the this side, one injection here, one injection here, one injection, no, the third injection is actually in the second layer only, but another a bit below. And then comes one injection, fourth injection here, fifth injection here. So this is called, this is called 5-in-1 block. Okay, 2 planes, 3 muscles. Needle, you don't have to poke multiple times. Needle is put only one time. So again, you see, I started from the supraspinatus area. Then I went in this side. As soon as I went this side, I saw clearly three layers. 3 layers I could see. Okay. So here I am focusing on the second layer. So which one is the second layer? This one is the second layer. Either it is actually rhomboid minor, and if I go up, then of course I will see the this boat shaped, actually this is the levator scapulae muscle. This is the levator scapulae muscle. So between under the second layer, there are so many vessels, and you can see, so these vessels only have come here. So here, this is the dorsal scapular nerve. This is the dorsal scapular nerve or artery under the second vessel. If I go a bit up, then also I can see the vessels. So this is the area. Here I can see the vessel also and accompanying nerve also. This is the nerve, which is a bit honeycomb appearance. This is the vessel, this is the nerve, this is honeycomb appearance. Okay, so I will go very you have to go inline, and you have to be very careful, because pleura is here. You cannot puncture pleura. So this is the dorsal scapular nerve, and this is the vessel. Okay, I think things are clear. You should not be confusing here. Color, sometimes it takes. So this is the artery, dorsal scapular artery, and just beside that, this is the nerve actually. This part is nerve. Okay, so now let us go to see between first and second layer. So between first and second layer, I will see that whether I can find the spinal accessory nerve or not. And where we will see between first and second layer means just above the second layer is our target in this way, in this area. So sometimes it is easily seen and sometimes it is not easily seen. So spinal accessory nerve is here in this plane. So here one black dot is moving here. Another vessel you can see. Another vessel is pulsating, but it is not taking color. So can you see this vessel? So this is pulsating in the group in this area, but it is not taking color. So anyway, we will not waste too much time in finding the spinal accessory nerve here, because these are plain block. We may not be able to find the nerve every time, but our during intervention, we will go inside 3 muscles and two planes. So one muscle is this, one muscle is this, third muscle is major actually when I go a bit below. And this is
Sir, injection should be around the artery or within the muscle plane, actually.
no, within the muscle and between the muscle. This fourth and fifth is between the muscle and around the nerves. And
You showed arteries, no, sir. I mean, you around the artery.
yeah.
No.
I showed the arteries. These arteries means arteries accompanied with the nerves. But then nerve, if you don't see clearly, that doesn't matter because we are
Okay.
giving in the plane. These processor, I mean injections are called hydrodissection of the nerve. So when you are giving 10 ml of local anesthetic here, that means you are just hydrodissecting the nerve. That's it. These are interfacial
E-
injections. That's it.
Either we can go around the nerve and within the plane. Either you're saying.
No, I'm not saying that either. This is 5-in-1 block has all the 5 components. You will do trigger point injection type of injection within the muscles. Okay. Here you are giving within the muscles, and here you will give the in the fossa between two muscles. Okay. Again, you will give here within the muscles, and here you will give around the nerve, but within the two muscle layers. Okay.
Okay, sir.
Like that. Okay. So this is
What's the total volume you use for the 5 block?
this is ultimately volume is dictated by this our mg, this your lignocaine dose. We can use up to 20 ml, 25 ml, no issues, but we have to calculate that lignocaine dose like 4 mg per kilo. We should not go in the toxic level. That's it. Because we are doing a hydrodissection, so I mean dose your volume can be more, no problem. Okay. So inside the muscle, of course, it is 2 ml, but inside the facial layer, you can go in the 5 ml, 6 ml like that. Okay, 5 to 7 ml within the fossa you can give.
Sorry, well, one more question. Would you put steroid as well or just local anesthetic?
No. We will not give steroid here. No.
Okay. All right. Thank you.
There are studies, of course, has given that 5% dextrose also can be given. Okay, 5% dextrose also can be done for the hydrodissection of the planes. These are facial layers. Okay. Okay. So these are the important things. I don't think. Okay. Just how to calculate the So I'm not okay. This part I will show in always. I always show in the thoracic vertebral here, that how to calculate the level, of the ribs. So during intercostal nerve, I always show. So now I'm not showing. Okay. Any more thing anyone wants in this area?
Sir,
Can you sorry.
Yes, tell
Sorry,
me.
you carry on.
Yes, please tell me.
You know the snapping shoulder syndrome. What approach would you do?
That is the I have also not got any patient of snapping shoulder, because
Okay.
scapulothoracic bursitis is an uncommon rare disease. I just told you because this can come. Our mind doesn't know, eyes don't see. So just to know that okay, this area can be, I mean, medial border of the scapula, someone having the pain, it can be a case of scapulothoracic bursitis also. So in this case, I will just hold the probe like this. Like this, I will hold to see that whether this part is bone. Okay, this part is bone. So as soon as I will just go in the border, I will try to see that whether there is a fluid accumulation there or not. But
we can't see the sorry.
Yes.
We can't see the ultrasound image.
No, here nothing to see. I mean, if there is no fluid in a volunteer, we will not be able to see anything. Yeah. So any more thing?
Sir, actually,
Yeah.
he was mentioning that during the last procedure, we were unable to see your pro position. Only your body was visible to the screen. You were visible.
Oh, okay. Just I show you. But then, okay. That I can show you. Actually, yeah, I'm managing both the things. So. Okay. Maybe in this way. Okay, just একটুখানি দাঁড়াও তুই ইয়ে কর সামনে দেখ so it is just না সামনে একটু ঝুঁকে so it is just oh understood okay here so this is the proposition this part is the scapular spine so this is the medial angle of the scapula so first layer we can see trapezius and supraspinatus in the right side so this is supraspinatus this is trapezius okay so here when I'm going medially then first layer remains same but second layer becomes the teres major actually this is teres major and if I go up then actually here another muscle comes this is the another muscle these two are separate this is one muscle this is one muscle this muscle is levator scapulae and this is the teres major so anyway so in this is the second layer and third layer actually very thin third layer is not very high I mean very thick so this is the third layer so mainly our search is for second layer. You can of course confirm that whether I can see the third layer or not like that. And this part is intercostal muscles. Okay, external intercostal, and internal and innermost intercostal. Okay, so here second layer is most important. Just below the second layer, you will search for the vessels, neurovascular bundle. So in this area. So here is the neurovascular bundle here. So I think you can see. So here is the neurovascular bundle. So this is the dorsal scapular nerve area. So you can, I mean, if you are injecting in the same plane, then you don't need to think about that. So you see, this is one plane for second and third, and this is another vessel for spinal accessory. So this is the first and second. So this is the area for spinal accessory. Now exactly this is the nerve or not, it is a bit difficult to tell because our probe doesn't show the nerve in a honeycomb appearance, but it looks like that this is the spinal accessory nerve. So the two planes are clearly seen, isn't it?
Sir, can we proceed on both sides? For example, if a patient has an issue on both sides, or in a single session, it is advised and to go in the next session. Others.
It is better to go in the next session. Otherwise, yeah, better to go in the next session. Let's see that, I mean, whether your diagnosis is correct or not, and whether patient gets relief or not. Okay.
Right. Thank you, sir.
And bilaterally, hardly patient comes. Maybe if someone can come, but in my OPD, I have always got one-sided problem. And mainly the people who sits in front of computer for a long time, and they get this type of pain. And of course, during treatment, we have to tell that they have to change their working habit and all. But at least simple trigger point doesn't work. But here 5-in-1 injection works fast. Patient will get relief for a long time. But then again, if patient do not change any day-to-day activities, then of course pain can come. Any muscular pain can come like that. Okay. So this. So okay. Nothing more. If any question, please ask. Otherwise, we will say good night.
Thank you very much.
Okay, welcome. Thank you. Good night then. Yeah.
Excellent lecture, sir, today. Really wonderful. Thank you. Very insightful today.
Okay, thank you.